So I'm going to record here. So yeah, so we're going to talk about elderly population. Then it kind of goes into palliative care, which you could be on palliative care if a younger person could be on palliative care if they, had some kind of terminal disease or cancer or something. But a lot of times we think about it with the older population, and then we're going to talk about the last two are really review. I like to preface that as like you have learned this stuff at some point in Sarmiento's class. I do believe. So the last two PowerPoints are abbreviated for partials, any kind of prosthesis, removable prosthesis or permanent prosthesis like a bridge, partials, and anything like that. And then the last one is implants, which is also, I'm pretty sure you guys have had two PowerPoints, one with McGee and one with Sarmiento. So again, it's just a refresher. It should be reviewed information. Some of it might just look slightly different because it's a PowerPoint from this class instead of theirs, but a lot of the information hopefully you have had before. Bless you. So we'll go into this one. So we got a lot of slides. So I'm going to try and just kind of go at a pretty steady clip so we can get through them all. Lots of objectives here. Mostly we're talking about this demographic, the characteristics and implication of as people grow older, what generally are the things that we want to be aware of with this population. I highlight this objective because there's an exam question around it. Well, many objectives have exam questions, but this one in particular is worded specifically and people tend to get it wrong. So it's just one of those things where I think people don't think it matters. And so they don't like listen to it very carefully. So I try and bring it out so you don't get the question wrong. But there's differences when we talk about this population based on chronological age, biological age, and functional age. Because you could be a young old person or an old young person, health wise, functionally, your dexterity, and I guess old might sound kind of rude, but you know what I mean by that is like you can either be 90 and like driving around and cognitively sharp and living on your own and looking quite healthy, or you could be 65 and literally be in a nursing home. So there's different kinds of ages is what I want you to think about. And then recognize common systemic conditions. So what kind of is more common among the elderly? Oral related changes. Explain how the process of care is modified for an aging adult. So we might have to do a fair amount of modifications, might have to do none, really. It kind of just depends. Educate aging clients on the important factors that should be considered when selecting a dentist. Define palliative care. So this also includes the palliative slides. I just kind of merged them together. So you want to understand what is palliative care, the purpose and the importance of palliative care, and assess oral complications commonly seen with people who are in or having palliative care provided to them, which is basically uncomplicated care to try to make them just feel comfortable during their last days. So the demographic of the aging population is absolutely growing. They used to refer to it a lot a couple years ago as the silver tsunami because all the boomers, are like aging out and retiring. And the boomer generation was called the boomer generation because there was a lot of them. So that was kind of like, why they had that title. And so once they all started to get to retirement age, they all started, there's more just aging diseases, systemic diseases. There's more of that population that has to be cared for. And so a lot of these common conditions that you see on the slide, heart disease, cancer, diabetes, stroke, arthritis. So there's just a lot more of that in the general population because there's more of this age group. So this is the characterization of aging. So chronological years, that's your actual, however many years you are. It's your chronological age is your actual age, how many years you've been on this earth. The biological age, an estimate of how old a person's cells are based on their chronological age and other factors like diet, lifestyle, and genetics. So I just did this huge, I'm going to try not to tell too many side stories, but I just did this huge blood panel just to kind of get a bunch of like markers. It was like 100 different blood tests. And it told me that my biological age is 0.7 years older than my chronological age. So I was so sad. I was like, I wanted to be biologically younger than I am, but I'm actually almost a year old, biologically older. And so we're going to work on that. That's next year's project. And then functional age is based on performance and capabilities. So that's, like just how cognitively sharp are they? How well is their dexterity and their ability to follow directions and understand the importance of things and be able to just do all these different kind of functional activities. We've heard the term activities of daily living, instrumental activities of daily living. So these are kind of review from almost, I think, our first PowerPoint when we were talking about special needs. And then acute conditions, those are going to be, those were more prevalent in the early 1900s when somebody would literally die from an infection. They'd have it like an acute infection. Their body would be like fighting against some kind of a bacteria or something, dysentery or something, and it would literally kill them. But nowadays we have antibiotics and we have so many treatments that now we have chronic conditions. That's far more prevalent today. So just understanding acute condition versus chronic condition. So there are some changes that happen when people get older in the oral cavity, but really the like the end cap or the big, the spoiler is that yes, there's changes, but really if you take a very, very healthy older person who has spent their whole life doing good oral hygiene, good activity, good diet, and maybe even good genetics, you could maybe put that in there too, but they just haven't had a lot of insult from environment and diet and lifestyle, they can have very minimal oral changes. So you could see really great dentition. You could see quite a bit of, bone and gingiva health and everything. But because of so many chronic conditions and because people are not always perfect with their diet and their oral health and blah, 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 we do tend to see pretty severe changes, but a lot of them are due to systemic conditions and drugs and things like that. So it's a little bit of both. There is some aging, but things can also look quite healthy depending on the person. So there's been overall dental changes. There's been a decline in edentulousness. So that's people losing, not having their teeth. So it used to be far more common for people to get their teeth extracted younger. And we don't see that as much. Now we'll see people might, individuals might miss molars or miss a tooth or a few teeth, but oftentimes they'll have bridges, they could have implants. So we don't see full dentures as much as we used to, although it certainly still is out there. Changes in enamel, cementum, dentin, and pulp. We do see things like just basic wear and tear. And again, this depends on really the person and their lifestyle and habits, but in general, you do start to see some hairline fracturing that becomes a little bit more obvious in the enamel, staining of the enamel from life, drinking wine, coffee, tea, smoking, tobacco, whatever it might be. There is a slower production of dentin. And then there is also kind of over time, a shrinkage of the pulp chamber. So older individuals tend to have less dental sensitivity, which is nice because, a lot of times you kind of worry about that if somebody has recession, you're like, oh, if I scale on their recessed, right there along where the CEJ is or right on the root, is it going to be sensitive? But older individuals who do have recession, they tend not to have as much sensitivity or dental sensitivity. We also see attrition and abrasion. That's things that, just come from, again, wear and tear. For pathology, caries, root caries is going to be probably the most prevalent thing that you're going to see. Certainly, a lot of times in this population, they might already have occlusal fillings or fillings that go off, to either the, mesial or distal side, or just a crown altogether. They might have a multi-surface filling already, or it might have been replaced with a crown. So you might see marginal or recurrent decay, and then certainly decay on the root surface is probably going to be a little bit, definitely be more prevalent in this population. And of course, the contributing factors are recession, the quality of their saliva. A lot of medications, we already know this, it causes xerostomia, and they're going to be on, usually this population is on a lot of drugs, so they're going to have a higher rate of hyposalivation or xerostomia. Inability to complete thorough oral care, just not, the dexterity is not going to be as there. The awareness of their mouth feeling dirty, we can kind of feel like the scuzzy, fuzzy buildup, but they lose some awareness, some actual ability to like feel and get their musculature to help cleanse the mouth when they're eating. Previous restored coronal and root decay. Anytime you have crowns and fillings, and especially if you have a filling in a hard to clean area, that filling is just probably not going to have a great lifespan. If you have a filling in an area that you didn't clean well, the chances of the person like turning over a new leaf and becoming an expert in cleaning that area is just not super great. It can certainly happen, and it certainly does. But if they're older and their dexterity and their awareness and their memory and all that kind of stuff is a factor, then that just complicates the matter. Overconsumption of soft, retentive, refined carbohydrates, frequent snacking. In the nursing home, older people tend to lose a little bit of that taste sensitivity. Things don't taste as good. Things taste more bland to older people. And so they tend to give them salty, sweet foods in the nursing home and softer foods. And so they don't have carrots and apples and, things like that. They tend to have pudding and applesauce and mashed potatoes and, things like that. So that doesn't help either. So periodontal changes. So two individuals with the same chronological age, one with a younger biological age, had fewer periodontal risk factors. So this is just saying that no two people are alike. No two 75-year-olds, 65-year-olds, 55-year-olds are perfectly alike. Somebody could just, have had different lifestyle habits, different overall health. And so they're not necessarily just, you're not going to get old and automatically get periodontal disease. That's like the take home point. So the immune system is less efficient with age though. And so, as we get older, obviously we break down. You could be a very healthy, 95-year-old. When I worked in Arizona, I had loads of older patients that I was like, can I be like you when I'm 95, if I make it to 95? But, obviously that's a very broad spectrum. So in general, we do kind of break down as we age. So our immune system might not fight off the pathogens that cause periodontal disease. Chronic inflammation, persistent inflammatory state is intricately linked to the onset and progression of periodontal disease. And it can compromise the integrity and functionality of periodontal structures. We know that. That's kind of just obvious review. Repair, tissue doesn't repair quite as well. Blood flow can be compromised, things like that. Lifestyle, again, nutrition, home care, smoking habits, drinking habits, accelerated aging, there's oxidative stress and DNA damage just from aging. So there are some factors going against us as we age, but there's also a lot of, things that can be done in prevention as well. Let's see. So oral changes in the mucosal. So one thing that, as older people age, and you don't usually see this until, usually 60, 70, 75. But one thing is older people's skin gets thinner, just everything kind of thins out and becomes a little bit more delicate. And the same with the oral mucosa. So like the buccal mucosa, it can just get an injury easier. It can get inflamed easier. If it's dry, if that's going to get inflamed even easier than before, because we need that saliva to protect and pH balance. So So certainly there is going to be some changes that kind of take place, but again, it's not just across the board a given. It really does sort of depend on the individual's overall health and the way, how healthy they've been through their lives. So in general, we can say the changes in a healthy individual would be minimal, but we don't see a ton of super healthy individuals. We just have so much chronic disease in the US. So, sometimes the actual data doesn't necessarily always pan out to what we actually see. So age related, there can be trauma, hyposalivation, epithelial atrophy. So that's like the thinning and the loss of the thickness of the mucosa, reduction in cell turnover activity, loss of elasticity. So stretching somebody's cheeks and lips and mouth area can be a little bit more uncomfortable, and sometimes cracking can be a little bit more common, especially if they're dry and fragile. So you just have to kind of be aware of that, offer things like Vaseline, and maybe even have them rinse with like a biotin prior to seeing them. So just think about things like that. Kind of look at what you're working with before you start going in there and pulling things this way and that. Loss of collagen, loss of taste sensitivity. So there are some of these changes, and some people have this more than others. The pathology, of course, if they have chronic disease, autoimmune disease, if they smoke, if they have lots of medications, polypharmacy, all of that is going to increase any of that you would see. Tongue changes, those sublingual varicosities, so the big, like purpley blue, that's just all the veinage underneath the tongue kind of gets more pronounced. If they have any kind of nutritional deficiencies, anemia, they can have that atrophic glossitis, the burning sensation, their tongue can get the papilla depapulated. No, I think I just made that up. Anyways, they can lose papilla and just kind of have a shiny, smooth appearance. Denuded, that's a good word. We'll use that one. Edentulous. The tongue can almost appear to grow in size if they have teeth, but I think it's more of just a spreading out of the muscle, like the tongue just sort of spreads out. A fissured tongue, that can certainly happen, especially if they have chronic dry mouth. Deeper fissures in the tongue, like that looks like a crack, especially down the middle and off to the side. The dorsum of the tongue can show a decrease in the filiform papilla, like I said, which gives that smooth, shiny appearance. So the tongue can change and does change as people get older. So there's some fissuring there. So salivary gland, in general, if somebody's healthy, they don't have a lot of chronic disease or take a lot of medications, they might not have any kind of salivary reduction or salivary flow reduction. But if they have all these other elements, then you will see it. So xerostomia occurs in about 30 to 40% of older adults. That almost seems kind of low to me, but that was one resource. Of course, that increases with diabetes, autoimmune conditions like Sjogren's, multiple medications. If they've had head and neck radiation, all of those are going to increase their likelihood of having dry mouth. So what do we do for dry mouth? We've talked about this all the time, and this is absolute review, but we want to encourage our patients to keep the oral mucosa lubricated. They can do that with kind of chewing on ice, sipping on water, sleeping with a humidifier, sucking on sugarless gum and mints or lozenges. They can use saliva substitute. There's lots of different kinds of saliva substitutes out there. So those are kind of the things that we want to encourage. And this slide is review for you, the purpose of saliva, and then what happens when we have diminished saliva. You guys have certainly reviewed this and the importance of saliva in karyology in Sarmiento's class as well. So drug-induced xerostomia, though, is one of the biggest factors in this population. A third of prescriptions are for older people, and most older individuals will take at least somewhere around 3 medications. But in a nursing home, it's anywhere from like conservatively 5 to 7, but easily as much as 15 meds. I mean, and you guys are now seeing that, right? Because your rotations in the nursing home. Did you go in your junior year, or is it just your senior year? The just senior, so you're just starting now. So you'll see those big face, well, they give you like a face sheet, but then they have the huge thing that, do you guys get to look through that for your patients or does somebody else look? It's, they give you, I know they give something, they used to call it a face sheet and it was like a summary, but they'll have like, if you ask for the whole thing, it's like a book. Do you guys have, do you get to see that at all or you do?
Now, but like through at the nursing homes, like all their stuff is like in one area, like their medical
Yeah.
as well as their, so you get like a whole.
You get the whole picture and you can kind of look through it. Is that part of your rotation is you'll review that whole chart and then cool.
It was at least where.
When you went.
Yeah.
I know you guys only get a few opportunities to do each rotation, but okay, so yeah, and the common medications, pain medication, analgesics, diuretics, high blood pressure, oral hypoglycemic, diabetes, antihypertensive, antidepressants, and then sedatives. Those are all major ones that cause xerostomia, and those are really common in the older population. All those drugs are really super common. Okay, so some more drug-induced changes. We've talked a lot about gingival enlargement with different kinds of medications, especially the anticonvulsants like phenytoin, cardiovascular drugs, the calcium channel blockers, immunosuppressants, cyclosporin. All of those can cause gingival enlargement. And they're all pretty different drugs. Different populations could potentially be taking those, but those are the main ones. And then for xerostomia, a lot of these ones that we just listed on the other page as well. So sometimes patients can have halitosis or bad breath. That can have to do with an upper respiratory condition. It can have to do with a stomach or GI condition, and it can certainly happen from pocketing food. So if they eat, breakfast, lunch, and dinner, and they don't get cleaned out very good, then certainly that's going to lead to some bad breath or halitosis. And that happens a lot in the nursing home. So one of the main things that I did when I was in the nursing home is I'd take a wet gauze and I just swab out the whole mouth with a wet gauze, making sure I was getting up in the vestibules because that's where the food tends to migrate. And older people just don't have the musculature, the chewing like movement of the whole, masseter muscles and all the things to like masticate the food and then bring it down into a bolus and then swallow it. It kind of just gets kind of smushed and pushed and so they just don't have the same ability, especially when they're in the nursing home if they're really older and they just have lost a lot of their functionality. So that's a really important. So food between the cheeks, lips, soft tissue, inability to swallow, loss of sensation, muscle weakness. So that all leads to it. And also like swallowing difficulty, that dysphagia. We see that in so many different conditions and chronic diseases, but certainly in the older population, they just choke easier and not necessarily choke like they need the Heimlich, but water goes down the wrong pipe a little bit, or they just have difficulty swallowing, a big thing of, food. So it's just all of that becomes a little bit more difficult as they age, especially as they get more fragile and older. Okay, so assessments, dental hygiene, process of care. So this is all kind of just running through the stuff that you guys know that you need to do, that you have to critically think through. So you're gonna think about their personal medical and dental history. What kind of medications are they taking? What's their lifestyle like? Where are they living? Who's living with them? What are their activities? And then what are the patient's concerns? And then other things that come up in that section when you're first meeting with your patient. The EOIO, the oral cancer screening, encourage your patients, especially if they still have the ability, if they're getting older, but they're still perfectly functioning, perfectly living on their own. They're getting older, but they're not old, and really encourage them to do their own oral self-care exams, looking at their oral tissue, checking out little things that change color, lumps and bumps, all that kind of stuff. So talking to them about the importance of that as they age. Radiographs, always keeping those updated, oral health status, figuring out like paying attention to their ability to perform oral hygiene. So as you see a patient over the years, you start to notice like, oh, their dexterity is not getting as good. They're not cleaning as well as they used to. Maybe they are forgetting dental appointments, or you can tell maybe they are forgetting to do oral self-care altogether. Maybe that's saying something is happening in their cognitive realm, maybe the first stages of dementia or something like that. You might notice that as their dental hygienist. Nutritional status, um, are they still being able to cook the way that they did before, eat the same kind of foods, financial changes, ability to chew their food, and then just their diet in a whole. Is it changing dramatically? Is there malnutrition as a concern? So all these things, it's a lot of things as a dental hygienist to kind of keep tabs on, and you don't necessarily go through it like a checklist, like a pilot on a plane, but you just want all of these things. You want to have that understanding holistically that all of these things can affect the patient. And it might be one of those things that's a bigger concern, but as a primary care provider, you want to just think of your patient as a whole and address these things as needed, and let those red flags pop up as you're thinking about your patient and as they change and the years go by and that sort of thing. So then there's physical modifications, just modifications to the appointment. So, getting into the building, is everything set up so that as they age, they with their walkers or a cane or an assistant from somebody, can they get into the office? Their ramps and handles, that help the patient. Do they fatigue easily? Are they more stressed than they used to be? Do they just seem more, unsettled than they used to? Short morning appointments is the default for patients that just seem like it's too much. Just do it in the morning, short morning appointment. That's just like the default answer. And that might not work for everybody, but in general, people tend to have more energy in the morning. They might feel better in the morning. Especially older people come the afternoon, they want to take their nap and they might just lose some energy. Offer to assist them with walking. Dental chair, this is a couple important things. Very common for older people to want some support behind their neck. Very common, they might even ask for support below their knees or their lower back. They might feel like when you set them back in the chair, it's flying back. Like, oh my gosh, and like this is the same speed that it's always been. But things feel different. They do feel more vulnerable. I've had patients where I literally set them back 4 inches. I stop it for a second. I set them back 4 inches. I stop it for a second. I set them back 4 inches. And then if they go, oh, that's good. That's good. I'll say, okay, just let me have like 4 more inches because I can't do this all day. And so sometimes you can talk them into it, and you just kind of slowly just let them acclimate, and that helps a lot. So especially if you just kind of like whir them back, they're going to feel like, you might have just set them on their head. But if you let them acclimate, that can really help a lot. So moving them back slowly. And then the same thing when you sit them up, if you set them up too fast, their blood just doesn't like regulate as easily. Sometimes they don't have that powerful circulation, and so that lightheadedness can happen. So you want to be real careful with that as well. Hearing and vision impairment. A lot of times we only have one way of doing things. We don't necessarily consider their hearing or their vision as much. We just have the one set of, like handouts, or we have the Casey video, or we talk to them. And sometimes patients, they might just kind of shake their head and smile, but they might not actually understand like what we just said, but they don't want to be bothersome. They don't want to make you repeat yourself. And so we have to kind of be aware, like, do they need some assistance? Do they need some other kind of support? Maybe we have to just talk to family and like tell them everything so that they can help remind our patients. So when you're talking to a patient, it was a problem in COVID when we had our masks all the time. That was a big barrier because a lot of times older people really like to read faces and they like to read mouths. And then of course the muffled from behind the mask. So when you're just talking with your patient, before you start your appointment, do it if you can, if people's sickness isn't a thing, talk to them without a mask on, because it really does make a big difference. Shouting to anybody, doesn't seem, sometimes it's ineffective and unnecessary if we just simply holler at them, but speaking usually like a slower, like I always talk too fast, but speaking in a slower rate, asking, can I repeat myself? Would it help if I say it again or in a different way instead of just yelling fast at them? That's usually not the best approach. And then a lot of times it's simply of the background noise. And I have an issue. I swear my hearing, I've probably told you guys this before. I swear my hearing is damaged from years of the high pitched suction and air, stuff in the office. And so anytime there's a lot of background noise, people's voices just, it just kind of all blends. And that, for sure is, an issue also with older people. The hearing aids, certainly they want to leave it in while you're doing instruction and talking to them. But when you go to use the ultrasound, it can like squeal. So you might want to remember to recommend to them to turn off their hearing aid, or take it out while you're using the ultrasonic, because that can be really bothersome. Caregivers, it's really important to speak to your patient, but really ensure that the caregiver is on the same plane. Like the caregiver knows all the things, they heard it all, they understand it all, but you really, especially if your patient still is pretty much cognitively there, you don't want to be talking past them to the caregiver. It's just, they feel like insignificant, like they're just a body that has to have something done to them. It's kind of feels disrespectful. And so really talking to them and then double checking at the end that the caregiver got all the points. And informed consent can be difficult depending on if the person really is able to consent for themselves. So you'll know that based on, just the person's condition, the caregiver, what the caregiver says, and you'll be able to work that out. But just understanding that sometimes they've lost the ability to consent and the caregiver has to do that for them, has to give the consent. So then other things to consider, does the patient need pre-medication? We know our main flags are going to be like an artificial heart valve or some kind of major heart surgery, usually nothing like a bypass, like if it's a coronary bypass or a stent was placed, usually not anything for that. It usually has to do more with a valve or a major prosthesis, but it could also be a shunt place. They could be very sick, just have a very unstable chronic condition. And so their doctors might think that they need a pre-med. So just always thinking about that and having that be a part of your thought process as you run through. Trying to minimize trauma just because we know their healing is not going to be as good as when they were younger. And being aware of the elasticity of the oral mucosa and retracting and their dry mouth, all of those things can just be more uncomfortable and you can cause more trauma if you're kind of careless there. And then just really specifying the OHI to their abilities, their dexterity, their cognitive ability, all of those things. Changing up maybe how you recommend they care for their mouth, depending on what they can do. At the end of the appointment, you want to raise the chair slowly upright because of that whole circulation thing. Allow them to sit there for a while. Don't let them jump right up. Sometimes people, older people in their 70s, early 80s, they just might not always, they sometimes don't realize how their body doesn't always respond as quickly. That's sometimes they'll trip easier. They won't pick their feet up as high just because they think your body's doing something, but your body does something else. So if they try to jump up too quickly because they've been laying there and they're tired of laying there, just say, hey, wait, I want to talk to you for a minute. Don't leave me. And, just try to give them a second to kind of recalibrate before they jump up too fast. and assess for any assistance that they might need, and then give them post-operative instructions, review them, or give them written, maybe printed out in larger print, give it to a caregiver, give it to a husband or a wife if you feel that's necessary. Frequency of appointments, certainly they could go along the same trajectory that you consider everybody else. If they're perio, you might put them somewhere in the 3 to 4 month. If they're pretty healthy, you might do 6 months. I've had some elderly people that are really healthy. Maybe they don't have too many teeth because they were, back in an age when maybe teeth were extracted as opposed to having a root canal and a crown or something like that. So maybe they're missing teeth, but the teeth they have, they keep really, really healthy and they don't build up a lot of calculus. So maybe they even go a year. I mean, their finances for elderly people can be much tighter. They might not have great dental, and finances are a big concern. And if they don't have to come in every 6 months, maybe you see them once a year. I mean, you have that ability in your office to decide this is what is good for my patient. So it could be more often, it could be less often. It just depends. Patients who wear full dentures tend to not want to go through the same x-rays and yearly exam, but it's just as important for them to have like a yearly pano and a yearly exam. And it's hard sometimes to convince them of that because they're like, well, you're not cleaning anything, but you're still looking at the oral mucosa. You're looking at all of the tissue and the bone. You're looking at the actual mandible with the pano to see if anything's formed or anything's changed, and then make sure that the denture's fitting, that it's not rubbing, causing some kind of keratinized tissue, some kind of infection like candida. So it's, that stuff wouldn't necessarily be something that the patient's aware of. So by you encouraging them to come in and have those appointments, you kind of can explain that to them. Otherwise, they're kind of like, oh, I don't need to come to the dentist. I have no teeth. It's like, well, no, nobody else looks in your mouth. Your physician doesn't look in your mouth. And so it is really important for them to come in. And those are just some changes we've kind of already touched on. For cognitive disorders and just all of the things that we have to think about with anybody, sometimes we have to approach the appointment very kind of slowly. They could get unsettled and disgruntled and upset easier. They could get confused. Why am I here? I don't like you doing that. All of a sudden you're like the enemy. And a second ago they were smiling at you. And so sometimes we have to slow way down, talk slow and reassuring. And then sometimes we have to change the subject completely and say, what kind of music do you like? And then just sit there and talk to them about music for a second and then go, hey, you can't sing real good if you don't have a healthy mouth. Can I check your mouth? And I don't know. You got to get creative sometimes. If somebody has Alzheimer's or dementia, you really do have to get creative. So sometimes you just have to go with the flow, talk with the caregiver, have them be a part of it. Simpler instructions, oftentimes speak slowly, short sentences, all of those things that we'd have to incorporate with different kinds of not just elderly people, but other kinds of cognitive issues with any age. So sometimes you have to teach the caregiver, and this goes again, not just elderly people, but anybody who has a caregiver. So sometimes you have to teach them how to perform oral care because they're not coming to you a couple times a week. They're probably just coming every couple months or once or twice a year. And so the caregiver really needs to know how to do this. So talking about positioning the patient properly, using, pillows, and maybe they're in a recliner, maybe they're in a wheelchair, maybe they're lying in their bed. And so kind of talking to them about accessing them, removing anything that's removable, cleaning it really, really well, soaking it in some kind of antibacterial soak or like a diluted bleach solution, physically supporting or aiding their daily oral care, realizing that it's important for that not to be neglected and the importance of it. So you have to give them that motivational interviewing pep talk so that the caregiver values it for their patient. visually inspecting the quality of their oral care. So teaching them how to retract, teaching them this is okay to do it. This is how you look in the back of the mouth. This is how you can visualize the teeth. They're not dental assistants, they're not dental hygienists, they're not dentists. So teaching them it's okay to stick your fingers back here and pull up and pull down and pull out and just whatever. And if there's some things that you want to be cautious about, helping them understand that. Visually inspecting tissue for oral lesions, encouraging the patient during and after care, provide written instructions for the caregiver. So just basically teaching the caregiver how to inspect the patient's mouth and then perform oral hygiene. We talked a lot about modifications in the special needs, and so all of that you can apply to the older population. The bigger the handle, the better it is for their dexterity. An electric toothbrush is great. A water pick is great. The different brushes that kind of like wrap around the arch, and so you don't have to like be as dexterous. You can just kind of do a simpler brushing motion. So all of those things, power flossers, swabs to swab out food that could be in the vestibule, the different rinses, avoiding anything that's drying, so alcohol, anything that's stings or burns, anything like that. Having them use something that's more lubricating and maybe has some fluoride in it or something along those lines. So all of those adaptive aids and what the patient can use. So professionally applied fluoride. So we have this 1.1% sodium fluoride, 0.4 stannous fluoride. These are prescriptions that are used to be kind of the common percentages that you would send somebody home with. I'm assuming they're still, I feel like things have changed in this realm a little bit. I probably should have updated it, but those were the percentage when someone would do a take-home tray. It would be, though, that would be the percentage. Stannous fluoride is one of those you guys remember from, this is review, but it's really good for sensitivity. It has a lot of benefit, but it does tend to perhaps stain. But I feel like they've been working on different products that help it not stain as much. So it depends on what your patient's needs are. If they're having a lot of sensitivity or you're worried about decay. This stuff is all pretty much review, so I'm just going to skip the rest of that. Okay. Palliative care. Let me see. I'm not halfway through. I'll do the palliative care, then we'll take a break. Then we'll go to the other ones. Okay, so palliative care definition, any form of care that focuses on decreasing the symptoms of disease. So a person who's in palliative care probably has end-stage cancer, they're terminal, they're not likely to necessarily live much longer. And so you're not trying to like do some hardcore, we got to get rid of this cavity, we got to get rid of this periodontal disease. It's let's minimize the amount of bacteria, let's minimize the amount of fungus or candida, that let's treat this mucositis so that their tissue is really much more comfortable, so their tissue doesn't feel as dry. Those are your main things that you're trying for palliative care. So decrease symptom severity for individuals with life-limiting illness. Care does not involve delaying or reversing disease progression. So it's not aggressive. It's not trying to remove all the disease in the mouth. It's just trying to keep things comfortable for the patient. Palliative oral care management and prevention or oral problems caused by disease or treatment of disease. So we're just managing what's there and trying to prevent things from getting worse. That's the take-home point. Focus on patients' immediate quality of life. So dry mouth, mucositis, sores, preventing any kind of sores or treating sores. So again, the goals are provide relief from symptoms, especially pain. That's like the main thing. So it's basically palliative care is keep the patient comfortable and pain-free. That's like the point of it, really. Support holistic patient care and enhance quality of life. Offer support to patients to live as actively as possible until death. So trying to support their needs and their comfort. And so that can look different for different people. Palliative care doesn't hasten nor postpone death. So once they get into that realm, they're not trying to necessarily aggressively treat anything anymore, but they're also not trying to overdose them on pain medications or something like that. Like they're trying to keep just the patient comfortable and support their desires. Okay, so standard palliative oral hygiene care, this doesn't look that different. It's kind of taking away the major therapies that we do, but it doesn't look that much different from a lot of things. I always kind of add the caveat of gentleness because sometimes patients can be very, very fragile and their tissues can be extra fragile. The oral mucosa can be extra fragile. So I kind of just say gentle, but brushing teeth, cleaning the tongue, lubricating the mouth and the lips. So it's just keeping the bacterial load down throughout the day. So definitely like at least twice daily cleaning. They might not have the ability to swallow or spit. So a lot of times it's things that are more viscous, little thicker gels, usually or using suction. They have these little portable suction things. Denture care for sure, that needs to come out at night, needs to be cleansed really super well. And they can put the dentures back in during the day. Utilize a mouth rinse if possible. So just something soothing, baking soda, if they can kind of swish and spit. Baking soda and water. Palliative care for intubated patients is a similar thing, but again, the suction toothbrush is great because then you don't have to worry about foam and liquid going down their throat. And then the disposable mouth props, they're styrofoam, and those help with any of these patients that just don't have the ability to respond as well or open wide. You can put those styrofoam disposable mouth props in and open up and then clean that area. You can use that anywhere. You guys might even use that at the nursing homes when you go on rotation. I don't know. So some of the major complications that you would see is the mucositis. That's the most common complication for, like we talked about, with cancer patients or somebody that's just very fragile medically. Ulcerations or other lesions, common with cancer, radiation therapy. Chemotherapy reduces that mitosis rate or the cell division. And so it's just a lot of times we see mucositis as a side effect of that. Keeping patients' mouth clean, moisturized to prevent, and then the topical corticosteroids can be used, but like they're saying, some of the best prevention is just swishing, keeping the pH of the mouth, keeping the mouth clean, swishing with the sodium bicarbonate and water mouthwash. Other complications certainly could be oral candidiasis because their immune system is very compromised, and just where, it's an opportunistic infection where it feels like it can flourish, it will. So sometimes they do prescribe antifungal either rinses or lozenges. They have like a lozenge that is an antifungal. So, and it can also be treated systemically as well. And if they wear dentures, they're going to be a higher risk for oral candida. And if they have dry mouth as well. So this slide, it totally probably should have taken this out or edited it, and I didn't. So this is, I'm going to make myself a note. So this magic mouthwash though, maybe it's fine that it's here because honestly, a lot of the mainstream population and dental health and things like that, they would still probably default to this magic mouthwash that is just sort of made at a compounding pharmacy. And it's usually a mix of antihistamines, antifungals, topical anesthetics, antibiotics. But like Tana's instructor Spencer, she talked about when she guest lectured, she was the first one to where I learned that is that a lot of times this is now officially they're like, that's not the number one go-to because it's actually harsh on the tissue. There's a lot of ingredients in there that is not friendly to the oral mucosa, especially if the oral mucosa is very fragile, very dry. And so it could be that a few things are still used systemically, but in general, as far as a mouthwash goes, that baking soda is the main thing. So the soothing baking soda, saline, water rinse. If is a lot of pain, obviously you can have lidocaine added or some kind of a topical analgesic. Um, but a lot of times the other thing, milk of magnesia is another one because that has kind of like a coating. And so sometimes that's also recommended. But a lot of these sort of concoctions are not recommended because they have too many other ingredients that could be irritating. Okay, good. I think we're on a pretty good track. So we'll come back at about 10 o'clock or maybe 1 or 2 minutes past 10, just because I got 9:52. So we'll come back at like 10:02 and we'll finish up. All right, we're gonna get back to it so that we can get through fixed and removable dental prosthesis and implants. All right, so the objectives for this one, we're just gonna talk a little bit about tooth loss and kind of the demographic around tooth loss and risk factors. I'm going to talk about hard and soft tissue changes associated with tooth extraction and sort of like what happens to the remodeling of the bone and everything when there's not a tooth in there. List and describe the types of prosthesis, explain implications for dental hygiene care. That will include the occlusion, kind of the fit, how it potentially could irritate the tissue and any lesions that can occur, and then the importance of caring for it, cleaning. And we'll also discuss nutritional considerations as well. Okay, so the terminology, so edentulous, we've already talked about that, derived from the Latin word edentatus, means being without teeth or lacking teeth, and then prosthesis, a fixed or removable appliance that's designed to functionally, cosmetically replace the missing teeth. So we kind of instinctually at this stage in your schooling, you all know why people probably lose teeth. A lot of times they lose them because of dental caries or periodontal disease, but of course it can also be trauma. It could be some kind of medical condition. That could certainly influence as well. A lot of times we see this happening more in the lower socioeconomic status. Inadequate access to care certainly is going to influence it. Low frequency of professional oral care or, just poor daily oral care. All of those things are going to influence it. So I had when I worked for the periodontist, he used to tell patients all the time, prior to 35, your major risk factor is caries. And after 35, you kind of go into the risk factor of periodontal disease. I don't know if that's anecdotal or if it's scientifically based, but I mean, anecdotally, you do tend to see that. Caries happens a lot more in the younger age population. Certainly, caries happens in the older population as well, but a lot of times you'll see either a mix of caries risk and perio or just more perio risk as people above 35. But certainly they can have both. It's not a blanket statement by any means. Okay, so issues experienced with tooth loss, psychological, so behavioral changes, embarrassment, loss of dignity. Certainly people do not like to be seen without, if they have full dentures or a very large partial that has a lot of teeth on the partial that just kind of clips onto a few, they don't like being seen without it. That's almost like, part of their their feeling of being a complete person is having teeth in their mouth. And when they take that out, it's, like removing an arm or something. It feels very self-conscious. And there, I've had, it's kind of a spectrum. I've had patients that did not want to take it out in front of me. And I would just say, I have to look at your tissue underneath your denture. I'll let you put it right back in, but I have to clean it and look at the tissue and make sure everything's healthy. And then once I'm done with that, I'll give it right back to you and you can put it in. And goodness, the minute I give it back to them, boy, they pop that thing right back in just because they're embarrassed. They just feel uncomfortable. And I've even had patients tell me, I don't let my husband, it's usually women, but I don't let my husband ever see me without my denture in, like ever. And so it's just a point of self-consciousness or embarrassment for some people. Not everybody, everyone's different, but certainly that could be true for a fair amount of people. Physiologically, this is a little bit more what we'd be more concerned with is just the changes that happen in the mouth. So if you don't use it, you lose it. That happens with bone. So a tooth in the mouth stimulates bone. There's blood flow. There's there's something in there. So the bone, all the normal processes keep happening, but the minute the tooth is gone, you start to lose some of that stimulation and some of that normal bone formation, and you just get a remodeling or almost like an atrophy. The bone starts to resorb, and so the ridge starts to shrink. And it can happen in different rates for different people. Like I have had amazing, I had this one lady she had full dentures at 18. When I saw her, she was in her early 80s and she'd had full dentures since she was a young person. And her ridge was still unbelievably ridgy. I mean, it was like she had a lot of bone. I was like, wow, that's amazing that you've had these dentures for so long. So she just, whatever it was about her body, but then other people can have teeth extracted and it just melts like butter. It just goes away. And so, and a lot of times we do see more of that remodeling. So residual ridge and alveolar bone resorption, oral mucosa, the membrane remodels as well, loss of oral facial muscle tone. So everything just kind of, when you don't have as much of structure, your face kind of sinks in. You lose height or volume between your nose and your chin. So you kind of lose volume in the buccal, your master muscle area, and then you lose height in this area. So it all leads to that sort of older look. It can be exacerbated by metabolic bone disease, postmenopausal osteoporosis, and poor calcium diet can also affect that as well. So issues experienced with tooth loss. So physiological, so just kind of talking more about the same, but problems from resorption. So discomfort related to the proximity of the mandibular canal. So think about how deep in your bone your mandibular canal runs. And as you lose bone and it shrinks, if the bone gets thinner and thinner and thinner around the canal, you can start to, and you have something rubbing in that area, you can start to have a lot of discomfort there. So that can be a concern. Paresthesia in the lower lip and chin related to the exposure of the mental nerve. Again, you start to lose the bone and you got that foramen, that opening, and then you start to lose that bone around it, and it's more an exposure to that nerve. Highlighting this because it's most certainly an exam question, diminishes stability and retention of the prosthesis as the bony ridge continues to flatten with time, and it's 4 times greater on the mandibular arch than the maxillary arch. So you're going to see that resorption of the bone much faster on the mandible. Irregular resorption can create numerous sharp spikes. So if there's anything in the bone that's sort of different, or some kind of different areas in the bone, if as it resorbs, it could expose that, and it could feel like like just a sharper bump of bone. Difficult to fit with exostosis, palatal tori, mandibular tori, large maxillary tuberosity. So if somebody loses their teeth and they need a full upper denture and they have huge like a torus or palatal tori, those things complicate fitting and suction and retention of the denture, and so there's all those kind of complications. Thankfully, there's a lot more denture retain, like implants that retain the denture, and that helps huge with the stability of dentures. Decreased stability, unbalanced occlusion, TMJ disorders, these are all can be problematic as they lose bone and dimension and just, based on their anatomy and how the denture fits. And then dissatisfaction with appearance. Patients might not like the way the denture feels. They might not like the way it looks. They're and you don't really know that until you're in it, like you might think one thing and then all of a sudden the reality hits and you're wearing this thing and you're like, oh, it feels uncomfortable. I talk funny with it. So there's all kinds of other issues that patients encounter. So for removable, you guys hopefully have all seen a fair amount of different types of removable. You can have all acrylic or kind of some kind of a plastic. You can have a mixture of the acrylic and metal. There's just different styles. They can have all different teeth configurations. I mean, it just depends on what the patient has. There's the complete dentures. There's a maxillary denture is going to have a full palate. It needs that suction to keep it up. And usually patients might even use like a little tiny bit of like an adhesive to really keep it stuck up there. And then they could have an overdenture that snaps onto implants as well. Just some terms, just to remind you of some terms. We have the abutments, which are the teeth that are usually the ones that anchor something, like anchor a bridge. And then we have the pontic, which is the artificial tooth. There's no root on a pontic. The abutments are the natural teeth that are usually just cut down, for the bridge or whatever. And then the pontic, there's no root. It replaces the missing tooth. Another kind of a removable, well, that's fixed also, just to kind of highlight that. That's a fixed prosthesis, not a removable. Another kind of removable prosthesis would be an obturator that we saw that can be used for cleft palates, oral cancer. Okay, so educating the patient, it's really, and the dentist and the dental assistant will do a lot of this, but so often patients are overwhelmed. And I'm telling you, of all the people in the office, the patients really learn and talk and like to talk to the hygienist the most. I mean, that's not to say that some patient doesn't feel completely connected with their assistant or their dentist, but in general, a dentist will spout off all this information. This is the problem. This is what we got to do. And this patient is just kind of like, okay, okay, okay. And then so often, if they do that during a hygiene appointment, the dentist leaves and then the patient will be like, what did they just say? What do I need? And then they want you to like talk to them again about it. Or they might not even say it. You could just tell that they look overwhelmed. And so you want to hit those points again with them. And it's just a really important relationship, and you just have a lot of influence on highlighting important things that you want your patient to pay attention to. So expectations, oral hygiene instruction, prosthesis use and care. So whatever is going to be some new thing, how are you going to clean around it? What are you going to do with it? Things like that. Regular periodic maintenance appointments. So you want to try and educate them on all this kind of stuff. So eating, avoid, so if somebody had, like a full denture, or somebody had some kind of a new prosthesis, avoid repeated gum chewing, sticky foods, use of the anterior teeth for repeated action, repeated chewing. So my mom is like a perfect example of this. She basically she has like mandibular molars and no maxillary molars. So she had basically from canine to canine on the maxilla is all she had, and she wouldn't wear her partial. She hated the way it felt, so she chewed all of her food on her anterior teeth. And so she needed crowns, and then she'd chip the crown, and she finally got 3 implants just this past year. And so now she has like some premolars to chew on, but I'm like, Mom, you need a molar. You need 1 molar at least. I'm like, get another implant. And she's like, well, I might want, I'm like, oh my God, it drives me crazy. But because I mean, your anterior teeth were not made to masticate your food, but sometimes that's what they got. consume smaller pieces of food. The chewing time is going to be lengthened if they're chewing with heavy, lot of partials or full dentures. It's just going to take them longer to break down the food, and they just have to cut their food smaller so that they can actually like handle it. Evenly distribute the food. You don't want all your food on the right side, and you'll just pop your denture like it'll go like wonky, everything kind of has to be evened out. So kind of even out the chewing on both sides. In the beginning, their speech will be changed. It will be altered. They might slur their speech or feel like you can just hear their tongue differently or airflow differently. A lot of patients complain about this and they feel self-conscious, they feel frustrated, but they will get used to it. It's just a learning curve. The appearance, educate them on what to expect. That vertical dimension, I couldn't think of that word when I was trying to describe it, but between like their nose and their chin, that they might get some loss, but hopefully when they're partial or their prosthesis is in the mouth, it'll look full, but as they take it out, they'll lose some of that vertical dimension, obviously because they don't have teeth there. And so obviously there's going to be some physical changes, reduction in lip support, sunken maxillary appearance, and increased chin prominence are all different types of changes. Super important to educate them on these expectations, like the bone resorbs. It's going to be different rates for different people, but the bone does resorb, and usually they need to come in quite a lot during that first year. So everything might feel great. Couple weeks later, it doesn't fit the same. Adjust it again. Couple months later, it doesn't fit the same. Adjust it again. And the dentist does this. You guys aren't doing the adjustments, but just being a support for the patient and kind of helping them know what to expect, reinforcing that information so that the dentist isn't the only one that tells them. Alveolar ridge continues to change throughout the life, but usually most of that remodeling happens in that first year. New dentures or relines are needed approximately every 4 to 8 years, and patients don't like hearing that. They would much prefer to believe that they get one set of dentures and it's going to last in their entire life. But they wear down. The mouth changes, and at some point they just will need new dentures. And then they should be permanently marked with the wearer's identification. That's super important if they're in a nursing home or an assisted living, but it's not a bad idea even if they just live at home. Because what if something happens? What if they have a stroke, they go to the hospital or something like that? So really having an identification on a denture is a really good idea, no matter how old they are. Oral mucosal conditions usually caused by improper oral hygiene care, extended denture wear, or poor prosthetic fit. So those are usually why they'll have some kind of an issue, some kind of a sore, some kind of something growing, bacterial growth or candida growth. Factors affecting the oral mucosa of denture wearers. This is pretty much like same stuff that will cause other things, but systemic conditions, chronic diseases, poor general health, salivary dysfunction. That's going to lead to the decreased tolerance. It's just not going to feel good. The denture, if their mouth is dry, the denture is just not going to feel good in their mouth. Food's going to get stuck to it, underneath it, way more. So I've had patients come in and they've had the adhesive, and then I'm like, can you take that out? Because I need to clean. And the adhesive is stuck to their arch. The adhesive is partially stuck to the denture. And then there's also food that's stuck to the adhesive. And it's just like, oh my gosh, what a mess. And it's hard to clean it all. It takes a lot. But so you kind of want to let them know, like if you know you're coming in to an appointment, can you just put the adhesive on after we're done? So sometimes you have to help them understand all these things because they just get up in the morning and squeeze that adhesive on and shove it up there. And then it just makes it a lot harder for you. So all of that is just part of the education. Obviously, if they have poor general healing, they can have impaired healing. They might be taking more medications, and all of that can just sort of snowball. Xerostomia, a lot of this stuff we've already talked about, but it can be even more prevalent, that frictional irritation, altered taste perception, cracked lips, fissured tongue, burning mouth syndrome. That's just exacerbated if they have a denture. I mean, it's just something more to be uncomfortable, to accumulate bacteria if they have a denture. So it's just a lot. All that's hard. Okay, so some reactive or traumatic lesions, it could just be rubbing and it could be a very, very small adjustment, but over time it can cause quite a sore. And it might not be apparent at first. It might just look like a little bit of a red area to you that you might say your tissue looks really red here under the denture. And then that's when that you want to say you should really schedule an appointment with the dentist, or maybe the dentist can see you today to adjust your denture. This is something I've seen quite a bit. This is an ill-fitting denture. The ridge comes up too high and it just rubs in the vestibule and it starts to keratinize the tissue. And it's called epilis fissuratum. And it'll go away or at least shrink way down if the denture is trimmed back or adjusted. But it's just from improper fit. So it's just like fibrous hyperplastic tissue. Other things that you can see a lot of stomatitis, and things can be layered. So there can be like a little of dry mouth irritation and then candida, like you could have layered. But candida can also present itself in different ways. Candida can look white patchy, candida can look red. There's different ways that it can present. Denture stomatitis, if right where the denture lays, it looks all red and irritated, and then the rest of the tissue, like the rest of the palate, if it's not a full covered, if it doesn't fully cover the whole palate, doesn't look irritated, then like A, they're sleeping with it, they're not taking it out, they're not cleaning it, or B, it just fits really poorly, and maybe still on top of it, they're not cleaning it. But like this, I've seen this a ton, where you can just see the outline of the denture. So you just have to educate them on taking it out, cleaning it. Angular cheilitis, that's another candida infection, and that a lot of times is just they're re-inoculating, bacteria or the candida is just really growing because they're not letting their tissue breathe, they're not letting their tissue slough, they're not cleansing that area, and so that's all the result of it. Prosthesis induced fibrous hypoplasia. So these kind of nodules where the tissue just gets thick and lobular and noduly. And again, it's just another reaction, chronic denture induced trauma, irritation, just from an ill-fitting denture. Palatal papillary hyperplasia associated with candida, just looks all kind of bumpy and red. Note the generalized granular erythema, change of the palatal mucosa matches the shape of the denture. Also note the denture-induced papillary hyperplasia on the palate. So those are just, usually it's those two things. The denture doesn't fit well, they're not cleaning it, they're not letting their tissue breathe. So those are super important points to share with your patients who have removable partials or full dentures. Daily oral and denture hygiene care, advise against denture home repair kits. Probably they're not going to be an expert. And I have literally had patients take Dremels to their dentures to adjust something, or they've used some kind of an at-home repair kit. Probably not a great idea, but patients will do amazing things. Discourage denture adhesives with a stable and retentive prosthesis. So if they need an adhesive, it should be literally a teeny tiny amount. So these patients that like put a huge thick ribbon of adhesive, and those patients have a denture that doesn't fit well, and so they shouldn't need that much. Just like a few little dots to kind of help with the maybe the cushion or the retention. But if they're using a ton, then it's probably not a good fitting denture. Encourage self-examination for proper fit, deposits, abrasion, lesions. Encourage them to take the denture out and really inspect their own mouth, pull back their lips, try and look at the ridge, look in their vestibule. Remove it at night to allow the tissue to rest. Probably the number one thing that you should know and teach your patients. brush denture at least, or at least rinse after every meal and before bedtime. Really, it should soak overnight. Um, they really, there should be no reason to wear it at night. They should let it soak overnight. Rinse saliva, loose debris, remove the adhesive. They can use, if they've had an infection like Candida, they are going to have to use like a diluted bleach to kill the bacteria, kill the Candida. They're going to have to like just use like, there's usually like, well, right there, 1 tablespoon of bleach to 4 ounces of water. So it's really diluted. It'll taste like pool water. And so they really are going to have to do that, or else they're just going to re-inoculate their mouth. If they keep using it, a denture that has Candida on it, they're just going to keep, it's a vicious cycle. So they have to really wear it. Like if they're going to wear it, they have to try and kill that while they're having treatment. Like if they're having a lozenge or an oral rinse for Candida, then every night they have to soak it and kill that, or else they're just going to keep inoculating themselves. Brushing the denture or the partial. They used to say don't use a regular toothbrush, and I swear they said because it's more abrasive than a denture brush. But if anyone's felt a denture brush, I mean, I'm telling you, I would go to CE courses and they'd like, don't have them brush with a regular toothbrush. It's too abrasive. I'm like, more than a denture brush? Like a denture brush is really stiff. So I don't know. Just see what the CE courses say. They do make a denture brush, Oral B I like this one. I used to give this one out because I liked the two sides and how the bristles were kind of peaked. But I've told patients to use they could not their toothbrush, but they can use a toothbrush. I don't know. I feel like it didn't make a lot of sense to me. So but I would usually recommend a denture brush because that's what they're made for. So that's what I would recommend. When they're cleaning it and when you guys are cleaning it, obviously you don't want, if it's metal, you don't want to squeeze it. You can change the form if you squeeze it too hard. And if it's all plastic, they can be slippery. And so clean it over a sink. Usually you line the sink with like some paper towel. So if you drop it, you don't drop it into the hard sink. I've heard hygienists say that, they've dropped them in the sink and it like chipped a tooth on the porcelain, or, I've heard things throughout the years. So you just want to be careful. It's your patient's teeth. So you don't want to do something careless, like bend it or drop it and chip it or something like that. Okay, yay. I think we're going to get through it all. So these are the PowerPoints that you had for these junior classes. You had implant maintenance and implantology in Sarmiento and McGee's class. So just always remember you can go back and review those. You're going to need that information all along the way. For the objectives for this is to understand the role of the dental hygienist in relation to implant maintenance. Define peri-implantitis versus peri-implant mucositis and explain how to make the diagnosis, detail the need for compliance with proper at-home implant care, discuss professional maintenance of dental implants. There are a lot of good CE courses. When you guys get out into the world, you'll see that there are, and sometimes you get a limited view when we go to these conferences. You don't always see, but there's lots of CE courses on periodontal disease is a massive one. I mean, it's always a popular CE topic with different speakers, different sort of philosophies, and then also with implants, different doctors who place implants and what they like to do in their practice. So there's a lot of information and sometimes it doesn't all jive. Some people have their preferences. So you just go out there and listen to it and kind of see what jives with you and the office that you're in. But indications, contraindications, and client selection. So there's no specific absolute contraindication for the use of dental implants. Other contraindications for oral surgery procedures do apply. So when I worked for Dr. Matsuda and he put in implants, if somebody was really sick, like had diabetes and it was uncontrolled or they smoked, he would give them like the rundown. You are a bad candidate for an implant. And he would just tell them, but they're like, I want an implant anyways. And so he's like, okay. And so he'd he put an implant in. But so it's not like somebody is, and I suppose depending on there are certain systemic diseases where I'm sure it really nobody would put an implant. Like if it was like some kind of a bone disease or something, um, but in general, they will pay attention to history of head and neck radiation, prolonged bisphosphonate use, and then poor systemic control. And that will be the dentist or the surgeon, the oral surgeon's preference on if they feel like they want to take on that liability. Certainly if they're well thought through and critically thinking with some of these patients, they wouldn't put an implant in because it would be destined to fail, especially in some of these particular like these bullets here. Contraindications should be, or considerations should be taken when considering a dental implant client's expectations, his or her willingness to participate in the treatment plan. It's a long process, although sometimes it feels like it's not being quite as long as it used to be. Are they a smoker? Are they going to comply with their oral hygiene? A lot of them think, oh, I don't have to clean it. It doesn't get decay. I don't have to do anything. It's like, well, if you lost your teeth for perio and you get an implant, you can lose the implant for perio reasons. So that sometimes you really have to push that education because patients just don't always understand that. So like review fabrication of a prosthesis often falsely considered the final step in implant therapy when maintenance is a key and ongoing factor. Prosthesis must be cleansable, maintainable interface between whatever is there for the patient to be able to get under it and clean it on a regular basis, but also for you to be able to get under it and clean it on a regular basis. And I've been out of practice long enough where I fear there's things that are out there that I've never seen. So you guys are going to see stuff, and this is just where your critical thinking will come in. Like someone's going to sit down in your chair and they're going to have something and you're going to be like, gee willikers, didn't see that in school. And you're just going to have to like use your critical thinking. Everything in the mouth has to be cleansed on a regular basis. And so what's the best tool to use? And so you've got to talk to your patients about that and consult with the dentist too. So shape, contour, texture, material, emergence profile, interproximal space, and tissue contact. So material and design, ever-changing industry. There's lots of different materials out there, different products, different companies that make implants. Typically it was titanium. I think that there can be some ceramic, carbon, other alloys, but very oftentimes it is titanium or titanium alloy. You have different types of implants that are at the bone level, or they might have a healing abutment. There's different parts. I used to kind of work in this field. So the ones that my dentist liked to use, I was very familiar with, but honestly, there's just a lot more out there now. And there's things that like I said, I probably have not seen. You can have a screw retained implant, or you can have a cement retained implant. So if it's a screw retained, usually you'll see a hole on the top and there's going to be like a composite or some kind of a material that kind of covers the screw. And then when they if they need to take it off for some reason, they would just access it through there. And then others don't want anything, marring the top of their crown. And so that would be cemented onto the implant. The crown would be cemented on. And that's fine as long as the cement hasn't squished out and caused an overhang of like some permanent chunk of calculus-like overhang that nobody knows is there and causes inflammation and a perio issue, which would be a problem. So another thing to remember as a review is implants. There's no fibers that are going to implant themselves into the titanium of an implant. The fibers are only going to go from the tissue to the bone and around the tissue. So there are no more of those fibers that implant themselves into the cementum and hold the tissue tight against the tooth. The only thing that holds tissue tight against the implant is those circular fibers and how healthy that tissue is maintained. So that's very different from a natural tooth. You can have keratinized tissue or non-keratinized tissue, and it depends on just the anatomy of, and what they're putting in. This is A is way more desirable. Having good keratinized tissue around an implant, way more desirable than this movable, squishy, wiggly, non-keratinized loose tissue. So if patients have that, or they have a very, very, very small band of keratinized tissue, oral hygiene is like, oh my gosh, check. You want to talk to them about it, keeping that healthy, because disease will travel much faster through that non-keratinized tissue. Two different things that we're thinking of. We're thinking of peri-implant mucositis. So around the implant, there's inflammation in the mucosa. And then, so that has defined as a reversible inflammatory reaction that resides in the mucosa and does not include loss of supporting bone. In peri-implant mucositis, bleeding upon probing, it would be present. So think about that as like gingivitis. We take it kind of seriously because we're like, oh, you don't want inflammation around this $10,000 tooth that's in your mouth. Peri-implantitis, defined as an inflammatory reaction that's associated with bone loss, implant around the implant that's in function, sorry, it's thought to be more difficult to reverse. So now the peri-implantitis is more like periodontal disease. So now it's affecting the bone level and that stuff. Signs of disease, progressive increase in probing depth. Now you might get deeper probing depths around an implant. You might get a 4, and that's might be totally normal and healthy for that implant. But it's when you get bleeding, the tissue looks boggy. The next time you get a deeper reading, you take x-rays and you can see that their bone loss is happening around the implant. That's what you're really worried about. Suppuration or exudate or pus around an implant is no good. You don't want that. Bleeding upon probing is just like anything, cautionary. You don't want bleeding. That shows there's some inflammation. Clinical appearance of inflamed tissue is going to look the same as your natural teeth. And progressive loss of supporting bone and follow-up radiographs. You always want to try and radiograph an implant in the same way. So if you can take like a really perpendicular image, even if it's like a vertical bite wing, even though you do want to see down around the end of the implant, but if you can see the bone level, if you can take a really similar image so that you always see a nice perpendicular or parallel technique, because if you have that elongation or foreshortening of you're gonna change where the bone looks, and so it could look like there's more bone when there's not, and you also want consistency year after year to get the same kind of image over and over again. So really, a bite wing is the best way to like look at bone height, and then maybe you'll also take a PA just to see the full implant. So maintenance for peri-implantitis, loss of the crestal peri-implant bone in conjunction with bleeding, mobility of an implant. If an implant is moving, it has failed. So we don't have an implant like a mobility, like class 1, class 2. No, if it's moving, it's failed. So the first step of management of peri-implantitis is to identify and remedy any local factors. Is there cement there? Is there calculus there? Is there just a lot of bacteria that the patient isn't moving? Sometimes we'll do non-surgical debridement. Sometimes they'll just flap it back. The dentist will clean it up. Maybe they have to like do some kind of surgery around the implant to try to, but most often any general practice, if an implant is not looking good, they will refer them back to an oral surgeon or a periodontist. For probing, very oftentimes your dentist will say, just use a metal probe very gently, but you could work in an office that says, no, we only trust these plastic probes that are I don't like that we don't, but they might feel that way. And if that's the philosophy of your office, then you have to, and especially if you're working for a periodontist or an oral surgeon and they only want you to use the plastic, that's their area of expertise. You kind of have to do what they want. But my doctor that I worked for liked the metal because he thought it was more accurate, and we just probed very, very, very gently. So there was no like hard poking down into that junctional epithelium. So light force pressure baseline may be deeper than 3. This figure is at implant you can see the difference to your follow-up. There's a lot of, the bone went down to the threads. So that's not uncommon to see the bone going down to the threads. And I think they've worked on design, because they almost always in the beginning expected a little bit of bone loss around implants. And I think they've done some different things like platform switching. It's like a type of design of the implant to try to minimize that initial bone loss around the implant. For scalers, there's some when I first started, they were the thick, full-on plastic, like they were like black and thick ends, and you could not get subgingival to save your life. There was like nothing you could do to scaler on, like if you had to get subgingival, but they've way improved. They've made them out of different metals. They can be Teflon coated, gold, graphite, the ultrasonic scaler. I have heard that the little tips, there's those like little blue tips. I've gone to lots of CE courses where they say do not use those. It embeds some of the plastic into the implant. So you just it's kind of all over the board, and there's all these different products, and a lot of times you just kind of learn what your office, but I know there's a capstone group that's going to be researching this, and I think it's really awesome because it does kind of feel like scattered information. Like it's just kind of like what's best practices, and oftentimes you just kind of do what your office does, and that's what you do. So titanium implant scalers are recommended on implants coated with hydroxyapatite. This is just different types of scalers that but some of the theory is if you are going to use implant that's made of titanium, you can have the material of your scaler be the same. There used to be a lot of concern with scratching the implant, and I think some of those fears have kind of gone. They're not as afraid of scratching the implant as they were when implants were first being put in, but that's still, I think, it can still be a concern. Oral hygiene, the water pick is great around implants. Thicker floss, the sort of ropier floss is really good. Proxy brushes, anything that stimulates the gum tissue, the gum stimulator. Toothpicks are cautionary. So you might work for someone that loves toothpicks. Others might say no, they could poke and cause damage just to the tissue around an implant. So again, there's just different schools of thought, but definitely something that's going to remove the biofilm on a regular basis. Implants ultimately fail due to loss integration, because I didn't use that word yet, but that's what the implant is the bone literally integrates with the titanium surface. It sort of like merges into each other, and it's rock solid. And so if you lose that integration, that's ultimately why the implant becomes mobile and fails. Removal of the implant is the only option. Sometimes they can bone graft it, wait several months, maybe put in a new implant. It just depends on the circumstance. Important to understand why it failed in the first place. Surgical therapy is superior to non-surgical therapy in resolving peri-implantitis, and therefore may ultimately be required. So don't feel like as the hygienist, you have to solve all the problems around an implant that's not doing well. It might be completely out of your hands. Like I've gone down subgingival and I could feel the threads of an implant, and to be able to feel like you're doing the right thing, that you're actually causing am I causing more harm than good? Am I actually cleaning even efficiently? Like sometimes it just is out of your hands, and the patient has to go back to the surgeon, and they have to deal with whatever is going on. If someone has healthy implants, just help your patients maintain those healthy implants, and hopefully you don't have to get to that stage where there's disease around them. And I think that's the last slide. Look at that. I'm great. Sorry, you guys, for just talking, but sometimes that's how it goes.